whenever there's like osmolarity change, when hyperosmolarity, there's a synthesis or there's a secretions of ADH that happens. Not only that, okay, let's say whenever you're fear, okay, or whenever you're stressed, let's say there is a high level of cortical releasing hormone is there, okay, like whenever you fear or whenever you're in emotional fear, emotional stress or pain, okay, let's say pain, okay, what is going to happen is that those stimulate the release of ADH. Because remember, what ADH does is that it retains the water, okay? So that's the reason why, remember, when you're fear, when you're stressed, do you want to go to the bathroom frequently? You probably don't go to the bathroom frequently, right? Just think about it. So because that's the time it stimulates ADH and releases more ADH, so that way it reabsorbs more water. So that way you don't have a frequent urinations. You don't need to go to the bathroom, okay? So that's why this during the painful conditions, emotional time, or during stress, or whenever there's a release of cortical releasing hormones, or during the hyperosmolarity, okay, or whenever there's a plasma level, let's write down here in the green, whenever the plasma level of, okay, during the plasma level of this extracellular fluid, let's say plasma level of fluid is going down, or like let's say having a decreasing lower blood pressure, right? All that condition, all this leads into, okay, stimulations of this supraorbital nucleus, and then you secrete more ADH, okay? Now, if there are, let's say, these are the factors, okay, like low level of plasma fluid during the hemorrhage conditions, let's say when you or dehydrations, okay, or there's a heavy loss of your fluid from your body, okay, or in hyperosmolarity, or during a fear or stress, emotional, or even the painful condition, this stimulates the release of the ADH, okay? Now, if these are stimulus, what are the factors that will inhibit the release of this ADH? Remember, one of the main ones is, let's write down ethanol here. What is ethanol? Alcohol, okay? Basically what it does is that your ethanol, right, or alcohol. And also one more thing is, look at this heart. Whenever you have your, the volume, extracellular fluid volume is going up, right? The preload is increasing, right? What is going to happen from this atria right here, right? It gets stretched, right? Whenever the plasma level of fluid volume increases, right? And whenever there's stress on this secretes very special type of hormone. What is that called? It is called ANP. Remember this? Atria neuropeptide, okay? Because that's what it is. So this ANP, okay, and this ethanol or alcohol, what happens? They will sort of like inhibit the release of, okay, this origin vasopressin. Remember, if the plasma level of fluid is going up, it's really, really high, then maybe we don't need that extra water to retain, okay? So what is going to happen is that will suppress the release of synthesis of the ADH and suppress the release of ADH, right? Also, the thing is that, like say ethanol, like when you're drinking alcohol. When you drink alcohol, have you ever thought about like why, you go to bathroom frequently, okay? If you drink alcohol, right? The reason why is because this ethanol suppresses the ADH, and then ADH would not able to retain the water from this collecting tubules, okay? So if you're not going to able to retain the water, what happens? There will be increase in what? Increase in urination, right? So you pee out a lot, right? So that is what this ethanol does. So it inhibits the synthesis and the secretions of your originating vasopressins or antidiuretic hormones, okay? Now after this, okay, we have to talk about that. Let's say that in these conditions, whenever this is either the blood pressure is going down, or let's say the plasma level is falling down, okay, they will secrete the synthesis of your supraorbital nucleus, and then they release more ADH. Remember, guys, I forgot one more thing. What also is, remember the angiotensinogen number 2? Remember that? Whenever the plasma level is falling, the plasma level of the volume of fluid that is falling down, we activate the RAS pathway, right? Renin, angiotensinogen, aldosterone system, right? And then angiotensinogen has a receptor down there, and they also synthesize what? This ADH. Or basically when you're dehydrating, right? That whenever there is a just loss of your plasma fluid, okay? So now, all this release stimulate the supraorbital nucleus, and ultimately what is going to happen is that from this neurosectoral granules, which are called Herring bodies, okay, they will release ADH, right? or ADH or originating vasopressin. So now whenever this originating vasopressin, like let's say this is circulation, right? Okay, we'll make this as in circulation right here. Okay, now this ADH is right here. Okay, now whenever let's say like this ADH is released circulation or originating vasopressions. Okay, what happens is they'll go from the heart, from there all the way go right here ADH, right? And then what's gonna happen? They'll go down to the like your kidney tubules, because remember in the collecting tubules, if I want to quickly tell you about this nephron, because it's a kidney right here, right? Kidney nephron. Remember, this is what? This is going to be your fenestrous capillary, basement membrane. This is going to be a Bowman space, right? And the Bowman capsules. This is going to be a proximal tubule cells, right? And then remember, this is where the water freely moves out, right? This is like a water tight here, okay? Water cannot move out, right? And this right here, this is my collecting tubules right here. This collecting tubules is completely depends on your ADH, right? Originating vasopressin. So what happens is there's a special receptor located here, okay? And this is associated with the GS pathway, okay? What happens is that, look, this ADH comes, that's right here. ADH comes, which is antidiuretic hormone. What does it mean? The name itself tells you something about antidiuretic, meaning it prevents the diuresis. That's what it is, okay? So it comes bound with the G in the cells, in the collecting tubule cells, okay? And what it does is that, all right, it's bound with this, and then it activates. Remember, this is a GS pathway, right? GS coupled with what? This is going to stimulate the, remember, this is going to stimulate the, because the G protein couple stimulate, they're going to stimulate the GS, okay, with the bound with the GTP, right? And then GTP is going to go, and what is going to happen? Stimulate this, that's adenyl cyclase right here, okay? The domain of the adenyl cyclase, and then ultimately product is what? Converting ATP into cyclic AMP, okay? And then cyclic AMP will activate the protein kinase A, right? And this protein kinase A, okay, do two things. Protein kinase will go specifically the zine right here, okay? Let's say this is my zine, and then it will start synthesizing more of this channel. These are water channel, okay? These are aquaporin channels, okay? And then what is going to happen is that, and then they will also phosphate on this, like this vesicle, because these vesicles, okay, contains a lot of these aquaporin channels, okay? And these guys, and these channels are aquaporin 2 channels, okay? And when put a phosphate group, they start fusing down here, okay? And when it start fusing down here, there's going to have a lot of this, let's say, this fusing down here. Okay, this is one channel right here. Okay, it's a fusing channel right here. It's making like a water channel right here, look. It's everywhere. So this is what is happening down here. Even down here, okay? So whenever there is a plantations of this aquaporin channel, which is a water channel, what's going to happen? The water, let's say water is coming down here, right? Let's say this water, let's say, okay, we'll make this a blue in water. A lot of this water is coming down here, right? So what is going to happen is that the water will come out. Look, the water will retain. And that's what we want to do, right? That's what we want to do. So this is how, okay? This is how ADH works on the kidney tubules or collecting tubules to reabsorb retain the water, okay? So it is preventing the what? The water loss. Because remember, it needs to increase what? The water retention, so that way it can maintain the osmolarity, okay? If there's hyperosmolarity, which basically means that there's more sodium, more solids are there, right? And then, I mean, there's less water, right? So because of that, we need to retain the water, so that way, we can maintain the osmolarity, or we can maintain the extracellular fluid volume. So that's how the ADH does, okay? Even a small amount of secretions ADH will do this, okay? But remember, ADH not only has this function, ADH also does go and works on the arterioles, okay, where the smooth muscle cells are there. Okay, it also there and do a constriction, like vasoconstriction. That's what it also does. But remember this, it needs to, okay, for that to work, ADH needs to work, release in a higher concentrations, okay? So there must be like ADH, okay? Higher concentrations of ADH must be released into the circulations for that to work, okay? And what happens is that, let's say this is like, let's say my smooth muscle cells, and we'll make this as, let's say, smooth muscle cells down here, okay? This smooth muscle cells, it will come, and this again, it's not associated with GS, but this is a GQ pathway, okay? And what it does is that when the ADH bound down here, let's say, or originating vasopressin, it will activate the GQ pathway, ultimately result into what? the breakdown to the IP2, which is what? Phosphatidylinositol biphosphate into IP3 and your DAG. Okay, and then DAG will activate what is protein kinase C, and then IP3 will go to the smooth endoplasmic reticulum right here. Let's make this as a smooth endoplasmic reticulums. Okay, and then what is going to happen is that it will cause the calcium channel to release lots of calcium, right? And the calcium will go and what? Because it's a smooth muscle cell, it will bind to the calbindin complex, right? Sorry, calmogenic complex, right? And then they'll activate those myosin light chain kinase pathway, okay? And then with that, the more, the cross-cycle bridges will form, and ultimate result is the contractions will occur, okay? That's what it does whenever there's a high level of ADH is releasing, all right? Now, that's what it does. Now, just quickly, I want to talk about a little bit of clinical correlations of that, okay? Sometimes I'd say, whenever there's, let's say this guy, infundibular stock is, let's say, severe, okay? If the infundibular stock is severe, look, the secretions of the ADH and oxytocins maybe decrease for like few days, but it would not decrease ADH secretion because synthesis happens in the supraoptic nucleus and the paraventricular nucleus. These are the storage form, okay? So even if this is severe, there would not be a problem of secretions of ADH and your oxytocin, all right? Now, couple of things. There are conditions called, sometimes what happens is that if this nucleus here, if it's not able to produce your antidiuretic hormones, okay, then there's a condition related to that. We call them like your central insipidus, okay, that's what it's called. What is this called? Central insipidus, which basically means is there's a problem with the nuclei where they're not able to synthesize and secrete ADH, okay? That's what it is. But sometimes, what happens, there's no problems with the synthesis. The problem is the receptors here, okay? Maybe the receptors right here on the collecting tubules, they're very resistant to this ADH hormone. If that happens, then we call them as, okay, this is a nephrogenic insipidus, okay? These are nephrogenic insipidus. Basically means is that meaning that this nephrons is not able to respond to the ADH, okay? So with these people, you're going to have frequent urinations, okay? Because there's a resistance on the receptors down here. So because of that, it is called nephrogen. Because it's kidney, that's what we call the nephron. And insipidus basically means it's a tasteless. That's what it means, okay? So that's what it means. So both as nephrogenic or, let's say, the central insipidus, okay? If we group them together, we call them a diabetic insipidus, where basically the productions of the ADH has been reduced, okay? That's what it is. So these are some of the very two important clinical conditions here. One is the problem with the resistance here, but there's no problem with the nephrogenic insipidus though, guys. There's no problem, okay? This one, there's no problem with the synthesis and secretions of the ADH, okay? It's a problem with the resistance. It's a problem with the resistance because these receptors are now responding to this ADH hormone, okay? Or the central insipidus basically means is that there's a problem with the hypothalamus where they're not synthesizing and secreting the ADH hormone, all right? So this is very, very important. Now, remember, here I talked about this important hormone, right? The ANP, right? And this ANP is only releases, okay, whenever there's an atrial stretch, okay? Whenever there's a high level of preload or whenever there's an increased level of like a plasma volume, okay? That's going to cause a stretch into this, or whenever there's an increase in blood pressure, okay? So that's going to cause this ANP, and this ANP can inhibit the release of ADH, okay?